I'm talking about velopharyngeal insufficiency now. So before talking about this topic, let me first explain the pathophysiology behind this. So what happens is that in the normal anatomy of nasopharynx and oropharynx, at the junction between the nasopharynx and oropharynx, there is soft palate, and then posteriorly there is uvula. Mm, then here is the posterior border of the pharyngeal wall, and there is lateral border of pharyngeal wall. So what happens during the process of normal speech, this the soft palate and the uvula will go posterior superiorly, whereas this posterior pharyngeal wall and lateral pharyngeal wall will come anteriorly. During the process of normal speech, there will be the gap between the nasopharynx and oropharynx will be closed, as a result of which as a result of this closed seal, so the voice that is produced from the subglottic area will go up into the oropharyngeal area, and from oropharynx it will come through the mouth as a sound. So the sound that is produced from the subglottic area is not divided due to the presence of the seal between the nasopharynx and oropharynx. So now, what happens in the case of velopharyngeal insufficiency is that this gap between the nasopharynx and oropharynx cannot be closed due to various reasons, giving rise to the sound that is produced from the subglottic area being divided into both oropharynx as well as nasopharynx. So when this sound that is produced from the subglottic area goes into the nasopharynx, there will be resonance. The resonance will be produced. So this resonance is produced in sounds that do not vibrate with very low nasal resonance, like a, e, I, o, u. So these sounds will have resonance, which is called as hypernasal speech, also called as rhinolilia aperta. Okay, now talking about the causes of velopharyngeal insufficiency. So the first one is structural cause, which includes the causes like cleft palate, which is the most common one. Then second one, there is adenoidectomy scar, which is the second most common cause of velopharyngeal insufficiency. Then there are causes like congenital soft palate, which is due to the dysfunction of muscles like levator veli palatini, which is the elevator of soft palate, tensor veli palatini, musculus uvula, superior constrictor, and palatoglossus palatopharyngeus. The second cause of velopharyngeal insufficiency is the neurovascular cause, which includes the causes like Parkinson's, head trauma, muscular dystrophy, stroke, and all, myopathies and all. And the third one is developmental cause, which includes the faulty articulation. And the fourth one is pediatric syndrome, which includes syndrome like trisomy 21, Turner's, Fell syndrome, and velocardiofacial syndrome, also called as VCAPS, which is due to the deletion in chromosome number 11. So the most common cause is overt cleft palate. Second most common cause is adenoidectomy scar, and and it is the most common cause in case of non-cleft patient is velocardiofacial syndrome. Okay, moving on. So talking about the symptoms, which includes the symptoms like hypernasal voice, or rhinolilia aperta, in the production of the sounds like a, e, I, o, u, which normally vibrate with very low nasal resonance. And the second one is facial grimaces. It is because of the effort because of the production of the it occurs along with hypernasal voice while this sound is produced. Third one is vocal nodule, which occurs in the long standing cases. The fourth one is shouting. So for the evaluation, a proper history should be taken. In the history of cleft palate, recurrent ear infection, surgery of the nasopharynx and pharynx, pediatric syndromes, sleep apnea, OSA, or any other presence of any other neurological diseases should be taken thoroughly. And the second one is examination. So under examination of nose, mucosa, turbinates, and septum should be done. The examination of oropharynx, examination of tonsils and its size, soft palate, uvula, bifid uvula. In uvula we have to look for bifid uvula. So the in soft palate we have to look for height, symmetry and mobility of soft palate. And for the palpation we do post palatal notch palpation and otoscopy for air, otoscopic examination for air. So for the assessment of speech production, so under evaluation, the third step we do is the assessment of speech production after history and examination. So for the assessment, perceptual speech analysis is a gold standard in the diagnosis of velopharyngeal diseases or insufficiency. So in this, the patient is asked to produce a fricative, applause and affricative sounds. These tests will help in the help to assess the hypernasal voice and grimaces that the patient can have. And the fourth modality for evaluation is imaging, which includes cephalometry or MRI. So usually CT is not done in this case because CT produces all those radiations which are very harmful for children, and since this is mostly diagnosed in children, so CT is not done. And also CT looks for the bone structures, so which is mostly not needed in this case. And in cephalometry is also done in case of children. And the fifth test is instrumental evaluation, which includes the tests like video nasal endoscopy, multi-view video fluoroscopy, or nasometry. So for the treatment, speech therapy can be given in case of mild BVD or articulation error or post surgery, and then and then prostheses can also be given which are anchored to the maxillary teeth. So it is given in case of poor candidates. And then the third one is surgery, which is done for the structural deformities. It is done only after 3 to 4 years of age. So what are the different surgeries that is done in case of velopharyngeal insufficiency are, so the first one is palate muscle repositioning, because the muscles of palate are also involved in this case in some cases. So pharyngeal flaps, sphincter pharyngoplasty or posterior pharyngeal wall augmentation can be done. So these are the four major modalities of surgeries that is done. Now this is the extra point: rhinolilia clausa and rhinolilia aperta. So rhinolilia aperta is what I discussed earlier. It is also called as hypernasal voice. It is because of the formation of a gap between the nasopharynx and oropharynx, as a result of which sounds like a, e, I, o, u, which normally vibrate with very low nasal resonance, they now vibrate with high nasal resonance. And then the next one is rhinolilia clausa, which means that there is due to some masses or tumors or any other masses that is present in between the nasopharynx and oropharynx. This gap between them is closed, as a result of which the sounds which require high nasal resonance like n, m, ng, so these sounds they cannot be vibrated with good nasal resonance, giving rise to hyponasal speech. So these two are the topics.